So the objectives for this talk are to gain an understanding of targeted therapy in cancer, review important molecular markers that play a role in targeted therapy, understand the molecular genetics of 4 tumors in which there's been a lot of new findings in the molecular diagnostics of these tumors that have clinical implications. So targeted therapy is now a very important tool to treating cancer. And an ideal drug target has several properties. It drives tumor growth, it regulates cancer progression, it can be reversible by inhibition, it's dispensable in normal cells, which can help reduce side effects, and you can measure its presence in your target tumor tissue. Now, traditional chemotherapy is not selective, and it basically, as we all know, targets all actively divided cells. So but in a tumor cell, if you want to try and use targeted therapy, you have different parts of the cell you can go after. You can target growth factor receptors, such as the HER family, the epidermal growth factor family, VEGFR, there's drugs against both of those. Signal transduction pathway kinases, things like RAS and RAF and MAP kinase that take the signal from outside the cell and bring it into the cell. Tumor-associated antigens that inappropriately expressed when the tumor of a cell are aberrantly expressed. Parts of the proteasome. Molecules that help to regulate the cell survival, apoptosis and anti-apoptotic genes. The molecules that get secreted in the extracellular matrix, these can be targeted. They can sometimes help to localize drugs to tumors. Anyway, these are all attractive targets that are being exploited for developing therapeutics. And in targeted therapy, there's 2 major classes of drugs. We have the therapeutic monoclonal antibodies. And these target specific antigens found on the cell surface, such as transmembrane receptors, like cetuximab, or extracellular growth factors, like bevacizumab, or small molecule inhibitors. And these can be typically taken orally. They penetrate the cell membrane and they interact with targets inside the cell. And these are usually designed to interfere with the enzymatic activity of the target protein. Now, these all have interesting names. As you know, they have the prefix and a stem and a substem. And from this stem, you can glean whether it's a monoclonal antibody or a small molecule inhibitor. The prefix is variable. That's the name of the group that develops the drug to use. And then the substem gives you some type of idea on the target. So for example, for monoclonal antibodies, these letters here can tell you whether it's targeting the circulatory system, the immune system, or the tumor. And then what type of monoclonal antibody is it? Is it a chimeric human mouse, a humanized mouse, or a fully human monoclonal antibody? That's going to be told by this stem here. Then for small molecules, they have a similar type of convention, whether it's a tyrosine kinase inhibitor, a proteasome inhibitor, and so on. So some examples would be cetuximab. These are both used to treat colon cancer. The TU tells us they're anti-tumor, but the stem gives you a little bit of information on whether they're fully humanized or chimeric. Then bevacizumab, instead of having the TU, the CIA indicates it's targeting the VEGF, and that's a humanized monoclonal antibody. So looking at biomarkers in tumors that can help predict the response to targeted therapy are tests fall into 3 major categories. DNA analysis, which is what we talked about earlier, looking at point mutations, insertions, and deletions, gene amplifications and fusions, and deletions of the tumor suppressor gene. Messenger RNA analysis can be done to look at gene fusion events, such as like BCR-ABL or EML4-ALK, or gene expression profiling, like the test that's used in breast cancer to predict recurrence, is essentially looking at 15 gene expression, the gene expression profile of 15 genes that have been validated to predict recurrence. And then there's protein analysis, immunohistochemistry, which is very easy and adaptable. We're all intimately familiar with that. And there's lots of different methodologies that can be used for detecting these different types of genetic defects in tumors. We talked about this earlier today, and up here, these are ones that are currently in practice. And there's a few tests that are FDA approved, but for the most part, these can all be lab developed, and depending on what resources are available or what your background is, different ones can be used for different types of applications. So now I'd like to talk about the different tumors and some of the important biomarkers. I'll start with melanoma. Melanoma is a malignant tumor of melanocytes. It's the 5th and 7th most common cancer in men and women, respectively. In the United States, in 2014, there's going to be approximately 76,000 new cases and just under 10,000 deaths. The treatment consists of a combination of surgery, traditional cytotoxic chemotherapy, targeted therapy, and immune-based therapies. However, when the disease is metastatic, the 5-year survival rate is very poor, around 10%. So novel therapies and treatment strategies are needed. With melanoma, you can kind of triage the cases into 2 arms in terms of the purposes of treatment. You have the cases where the BRAF gene is wild type, and that's about half of melanoma, and the other half where the BRAF is mutated. And mutated BRAF responds to a drug called vemurafenib, also known as Zolboraf. And there's a new drug that targets the PD-1 ligand that was just recently approved, and that can also be used in melanoma. So the treatment strategies are different based on the molecular status of the disease. And historically, melanoma has been classified according to pathological and clinical characteristics, which include the histology, the depth of the tumor, the Clark level, the ulceration, anatomic sites, and other pathoclinical features. But it can further be subdivided or classified at the molecular level by recurrent driver mutations. So if you look at subsets of melanoma, they have based on some clinical features, like whether the melanoma is in an area where there's no sun damage, typically areas of the body that don't get a lot of sun damage versus chronically exposed skin, or if it's in the mucosal surface or on the acral surface or in the eye, there's different mutations have a more likelihood of being present than other ones. And with this, in melanoma, the targeted therapy has really grown in the last 3 or 4 years. I'm going to try and pronounce it. This drug was first approved in 2014. It targets the CTLA-4 gene, and just recently, pembrolizumab, was targeting PD-1, was approved earlier this summer. And these all actually are trying to show some benefit for patients, and they can respond, but they all have targets. So demonstrating the presence of this target, with the exception of this last, this does have a target, but it doesn't have a biomarker that's used for this indication. But these targets are used to help select patients. And the cost of these drugs are massively expensive. It's ranging around $7,000 to $12,000 per month. So very expensive drugs. And these mutations are typically somatic, with BRAF being the most common and NRAS second most, and on down to more rare variants and less prevalent in melanoma. And these mutations are typically mutually exclusive. There could be driver mutations, and they are present. And so if you detect like a KIT mutation, it's very unlikely to find a mutation in any of these other genes. So BRAF is a very important gene. This is the serine threonine kinase. It's downstream of the RAS gene in the MEK kinase signaling pathway. It has 18 exons, and in exon 15, there's an activation site within the kinase domain. And within this exon, there's an amino acid at position 600, and it's normally a valine. In melanoma, this valine is typically substituted due to a point mutation, a single nucleotide variation, to a glutamic acid, and that's about 80 to 90%. Less commonly, it can be changed to a lysine, an arginine, or a aspartic acid. And this is important to know the genotype of the BRAF mutation because the drugs are been approved for specific genotypes. The E, K, and R are all sensitive to some type of BRAF inhibitor. V600E and K are sensitive to a new MEK inhibitor, trametinib. V600E has been approved for vemurafenib, and V600R is believed to be more sensitive to dabrafenib. So it's important to get the genotype of the tumor because that can allow the oncologist to pick the more precise treatment for the patient. But patients who go on these inhibitors invariably become resistant and tumor progression occurs. And this can be anywhere from 6 months to 18 months to 2 years. And the reason for the patients progressing and becoming resistant to therapy is typically due to reactivation of the MAP kinase pathway or other cell pathways that allow you to bypass the inhibition of the MAP kinase pathway. Now, unlike EGFR, secondary mutations in BRAF gene that might prevent the drug from binding have not been described. So this lists some of the different mechanisms of resistance to overriding BRAF inhibitors, but right now the proven and validated implications for targeted therapy are unknown. So once a patient becomes resistant, their treatment isn't fully defined and validated. This has to be handled by the oncologist using their best judgment. Another important mutation in melanoma is NRAS. NRAS is part of the RAS family, which includes KRAS, which we've all heard of, and HRAS. It's a serine threonine kinase. It functions just between the receptor, the tyrosine kinase receptor, and the BRAF gene you just got done talking about. It's mutated in about 15 to 25% of melanoma. It's also frequently mutated in other cancers. The mutations are found in codons 12, 13, and 61. And at position 12 and 13 are two glycines. And these are mutated to an amino acid that typically has a charge on it. And then 61 is an asparagine. These mutations are typically mutually exclusive to the BRAF activated mutations. And as of now, there's no approved anti-NRAS therapies. So the role of NRAS mutations in selecting or prioritizing cytotoxic chemotherapy and targeted therapy is not fully established at this point in time. The gene MAP2K1, also known as MEK1, is another important mutation in melanoma. It's in about 6% of melanomas, and these are the most common amino acid changes in patients with mutations in this gene. The prevalence in the different subtypes is not known. And these mutations can occur contaminated with either BRAF or NRAS mutations. So it's one of the few exceptions to the mutual exclusivity. And its role in selecting targets is unknown. But there are inhibitors against MEK that can be used in either alone or in conjunction with BRAF inhibitors. And this is under investigation to see how much more they prolong survival than when they're used as solo agents. GNAQ and GNA11 are two G proteins that are coupled to a G protein coupled receptor. So the ligand binds to this G protein, which is a 7 transmembrane pass receptor, but it lacks intrinsic kinase activity of its own. So it's very different from like EGFR, which has built-in kinase activity. So it uses these G proteins. So when it binds the ligand, it activates these G proteins, puts them into a GTP-bound state so that the G alpha subunit dissociates, goes into the cytoplasm, and turns on some type of pathway. And then the GTP gets hydrolyzed to GDP, and then it goes back to the inactive state. So just like the RAS gene, it shuttles back and forth. But mutations in GNAQ and GNA11 leave it in a pseudo-GTP-bound state, so it's constitutively activated, and that causes constitutive signaling and transformation of the melanocyte. So these are very common in uveal melanoma and in metastatic melanoma. You can find them in primary uveal melanomas and uveal metastatic lesions at a high prevalence. These mutations are mutually exclusive because they're functionally redundant, and there's no anti-GNA11 therapies available. But it does cluster and associate very much with the uveal origin of melanoma. KIT is another oncogene, it's the tyrosine kinase receptor that's mutated commonly in melanoma. You see it more often in aquamelanoma and mucosal melanomas. It's the same mutation profile you see in GIST and other tumors that have KIT mutations, and the exons 9, 11, 13, and 17. When a nucleotide substitution occurs here, you get an amino acid substitution. This induces ligand-independent receptor dimerization, so the receptor gets activated in the absence of a ligand, leading to constitutive kinase activation and transformation. KIT mutations are exclusive with other driver mutations in melanoma. And clinical trial data to date shows that patients with KIT mutations show some response to the imatinib, which is Gleevec, the dasatinib, sunitinib, and sorafenib. Beta-catenin, the CT, which is coded by the CTNNG1 gene, is also mutated in melanoma. It's not commonly mutated, about 2 to 3% of malignant melanoma. It's rarely detected in uveal melanoma. Its correlation with sun damage is unknown. It has two hotspots, both serines, serine 37 and serine 45. What normally happens during beta-catenin signaling is beta-catenin gets phosphorylated by a gene called glycogen synthase kinase 3 beta, or GSK3 beta. This phosphorylates beta-catenin, and that leads to the degradation of beta-catenin. So beta-catenin levels are highly regulated normally. Now, when you mutate these serine residues, the idea is that this phosphorylation sites are now destroyed. So beta-catenin now accumulates and becomes stabilized and goes into the nucleus. So you predict that immunohistochemistry staining of melanoma with beta-catenin mutants would show nuclear staining. And when it's in the nucleus, it stimulates the transcription of TCF, LEF, those are the same molecule, responsive target genes. So it turns on transcription of downstream genes that promote cell growth. So melanoma can also be a diagnostic challenge for pathologists. The subset of melanoma is difficult. The different terms of diagnosis are described here. This is a dilemma for both the clinicians and the patients regarding the proper prognosis and treatment for the patients. But one aspect of melanoma that's different from conventional nevi is that copy number changes are common in melanoma, but not in nevi. And by looking at copy number changes, it can help with the diagnosis. And this can be done either by fluorescent in situ hybridization or by array comparative genomic hybridization, also known as array CGH. So in melanoma, we frequently see gains of 1q, 6p, and these other chromosomes here, and losses of these chromosomes. Interestingly, in Spitz nevi, we frequently see gains of 11p in about 20% of Spitz nevi. These are typically Spitz nevi with an epithelioid morphology, and they behave somewhat more aggressively. So looking at 11p in Spitz nevi could be helpful to gain a better prediction on the behavior of the tumor. When FISH is used to look at these loci, it's targeted, whereas when array CGH is used, it looks at the whole genome, so it's more agnostic towards the genetic landscape of the tumor. In the last several years, several papers have been written, primarily authored by Dr. Jarami in Chicago, describing a FISH panel that can be used to help diagnose challenging melanoma cases. And what it is a 4-probe panel that includes these genes right here. One of these genes, 6q23, is the same gene that Dr. Krause talked about earlier in lipogenic tumors. However, in melanoma, you see a loss of this allele, whereas in the cases he described, you see a gain. So it's kind of interesting how same loci but behaving differently in different types of tumors. And by putting the probes on the tumor and using these scoring criteria, it can help you have about a 70 to 80% specificity and sensitivity for diagnosing the tumor. The advantages of doing FISH are that it works well with small samples such as biopsies, and you can detect abnormal subclones within the tumor. The disadvantages are that you're only looking at these 4 targets. So you could have copy number changes that don't include these loci, but different loci in melanoma, so you would miss those. Another issue with this is that the enumeration or the analysis of this FISH probe set takes some training and is somewhat sophisticated. So the technicians or pathologists who look at this need to spend a lot of time learning how to do that. Not all melanomas are FISH positive, and sometimes lesions can become tetraploid and polyploid, and this can confuse the analysis. To make and improve sensitivity, 2 of the probes have been dropped off, and there's been described a 5-probe system for doing FISH that also looks at these additional probe sets, and that's just slightly improved sensitivity and specificity, and can also work with Spitz nevi and other markers that can potentially be used around chromosome 3 and 22q11. As an alternative to doing FISH, there's array CGH, and unlike FISH, which would just look specifically at certain targets in the genome, array CGH looks at gains and losses in the entire genome. So this could be helpful when you just don't know if your FISH assay failed, or if you're looking for different targets. In this case, blue shows copy number gains and red shows copy number losses. This is from a collection of aggregate of 25 melanoma cases. The benefits of doing CGH is you can interrogate the entire genome in a single assay, and it'll provide information about additional abnormalities not detected in a FISH panel. The limitations are that you're working with FFPE, and until very recently, doing array CGH FFPE was incredibly technically challenging. But there's been new labeling kits that have come out that allow you to label your probes effectively so they work well with DNA that's derived from FFPE. And to do that, since you're comparing this to a standard normal diploid genome, you also have to degrade your reference material equally to the DNA duration that happens in FFPE, and you need a lot of DNA, 0.5 to 1 micrograms. So this would be several slides that you have to shave off. Also, there's some problems with, you might have CGH negative melanoma, and this could be just biologically, your sample just doesn't have it, or it can be analytically. The lesion that you're trying to interrogate is just too small. So this doesn't really lend itself well for small samples. And then the argument could be, well, if it's a large sample, my diagnostic challenge is not as bad as it is on the small sample. So it may have a more limited role than FISH, but it is an option and people do use it, or labs do use it. Okay, now I'm going to switch gears and I'm going to talk about lung cancer. So this is the number one cause of death in the United States and the number one cause of cancer. It's traditionally treated, its traditional treatment was historically determined by histology and based on and it was a platinum-based chemotherapy regimen. Survival rates with advanced lung cancer are very low, and they continue to be very low. The molecular genetics of squamous cell carcinoma are lagging behind in adenocarcinoma. Most of the recent advances have been in the adenocarcinoma histological subtype, and the driver mutations in lung adenocarcinoma are more rare in squamous cell carcinoma. The drugs bevacizumab, which targets VEGF, and pemetrexed are not approved or exhibit diminished efficacy in squamous cell carcinoma, so it's important to make a histological distinction. And patients with metastatic squamous cell carcinoma have fewer treatment options than those with non-small cell lung carcinoma. And just for the sake of completeness, and I believe I'm going to talk about this in a subsequent slide, the driver mutations that are typically found in squamous cell carcinoma include FGFR1, DDR2, and PIK3CA. So historically, lung cancer, as well known, was classified based on histology. But now it's being categorized based on its molecular aberrations. And there's a lot of different molecular alterations that have been found in lung cancer. Both EGFR mutations and ALK gene rearrangements have drugs that are FDA approved. Some of the mutations found in lung cancer are found in other types of tumors which are FDA approved drugs, such as BRAF and DDR2. And then other mutations, which are still rare but present, when you consider the number of cases of lung cancer, 1% is still thousands of cases per year. There's drugs that are being in clinical trial. So genotyping the patient's lung cancer does have clinical utility for the patient. Of all those mutations, a subset of them are what's known as driver mutations. These are very important. They're typically the major mutation that's driving the tumor, and they're the ones that are best to be targeted. In about half of lung cancer, no driver mutation is detectable. About a quarter of them show a KRAS mutation, which unfortunately right now is not druggable. EGFR mutations are very common, and then there's a spectrum of other mutations present. This pie graph does not show the ALK EML4 gene rearrangement, which is about 3 to 5% of lung cancer, so the third or fourth most common variant. A study that was done recently in Europe called the Direct study took patients with stage 3B or stage 4 non-small lung cancer who had mutations in EGFR and exon 19 or 21. These are mutations that predict a response to erlotinib. These patients were chemo-naive. They'd had no treatment within 6 months of the start of the study. And they were put either onto erlotinib or conventional cytotoxic chemotherapy that included platinum, then followed them. The primary endpoint was to look at progression-free survival. And what the study showed was that treating patients with an EGFR mutation with erlotinib compared to conventional chemotherapy had a better survival rate. So it's kind of helping to prove that it's important to determine the EGFR status, because patients who have EGFR mutations can go on erlotinib are more likely to survive than patients who don't have that testing done and go on to the conventional chemotherapy that includes a platinum agent. So the first generation of EGFR inhibitors were gefitinib and erlotinib. There's another drug that was developed in China called icosapent. There's some second generation EGFR inhibitors that are coming out now, including afatinib and these other ones. And these can either be used in patients who have not developed resistance to erlotinib or as an alternative to erlotinib, and then there's additional drugs in the pipelines. So these are good drugs because patients who have metastatic EGFR mutant tumors treated with these inhibitors have a median survival of 2 years, which is much longer than their survival would be without these drugs. And it's believed now that these mutations just on their own have a positive prognostic impact. There's slightly better prognosis in patients who have a non-mutated EGFR gene. The mutations in the EGFR gene are located in the kinase domain of EGFR. So just to back up a little bit, this is chromosome 7. It shows you the location of the EGFR gene, which is right here, right near the centromere. This is the gene. It's a transmembrane tyrosine kinase, so it binds the ligand on this portion of the molecule, and this is where the kinase domain is. And within the kinase domain, there's 4 exons 18, 19, 20, and 21. The vast majority of the mutations in EGFR are either deletions, in-frame deletions in exon 19, or a single nucleotide change in exon 21. And those 2 types of mutations predict sensitivity to erlotinib. There's about 3% of the cases have a mutation in exon 18, and these are also positive for erlotinib. Exon 20 is where the resistance to erlotinib mutations are found. So when a patient's being tested and screened for EGFR mutations, it's important to screen all 4 exons, because if you find a T790M mutation or an insertion in exon 20, this predicts lack of response to erlotinib, and that's important information to convey. In addition to EGFR, there's other mutations include BRAF, HER2, and these other genes listed here. They're not very common. These are the major variants associated with each one of these genes. And these are some of the drugs that are either available or in clinical development that would target patients who have mutation of these genes. A second class of mutations in lung cancer are the kinase fusion genes. And there's 3 major kinase fusions. There's ALK, ones that involve the ALK tyrosine kinase, the ROS tyrosine kinase, and the RET tyrosine kinase. Collectively, these are about 6 to 10% of lung adenocarcinoma. These are driver mutations, and they're significant clinically because they can be targeted by crizotinib for the case of ALK and ROS. ALK typically rearranges with the gene right next to it called EML4. It's an intrachromosomal deletion, creates a fusion protein, which the kinase domain of ALK is fused to a molecule that has a coil-coil domain. And when it's expressed in the cytoplasm, the coil-coil domain causes a dimerization, or a homodimer to form. And then the kinases, the 2 kinases are opposed to each other, and they autophosphorylate and activate the molecule. So you have this molecule floating around the cytoplasm that's just stimulating signaling and stimulating growth. But because it's a kinase, you can target it. Less commonly, ALK confused with KIF5B and TGF. This is important because there's ALK inhibitors, and so the presence of one of these translocations predicts increased sensitivity, and it also predicts decreased sensitivity to EGFR inhibitors. And there's other classes of inhibitors such as HSP90 and anti-EGFR, and the presence of EML4 ALK or these other ones could influence the prediction on the sensitivity to those. So the FDA-approved assay for detecting ALK is a FISH assay. There's 2 probes. One binds to the 5' end of ALK, and that's colored, it depends where you buy your probes from. It can be either green or red, and then there's a 3' probe. And then EML4 is the next gene just next door to ALK on chromosome 2, and it's in the anti-parallel direction. So they're kind of opposed to each other, and they're very close to each other on the chromosome. So if you were to take a normal cell and probe it with these 2 probes, the 2 probes will bind to the maternal and the paternal chromosome right next to each other, and you'll see through. And in real life, it would look like this. Now, due to a paracentric inversion, the genes get rearranged, and now these 2 probes are far apart from each other, so they're split. So what you would see would be one fused signal for the intact chromosome, and then the split signal. Sometimes you lose this 5' green signal, so you just see the red 3', which is where the kinase domain, and that's also considered to be a fusion. And you need to see this in 15% or more of the malignant cells to be considered FISH positive. Now that's hard to score too, because that separation that happens is very narrow and it can be easily missed. So there's been some ultra-sensitive antibodies that bind to the kinase domain of ALK, and they're commercially available. The 2 clones that are good for screening lung cancer for ALK rearrangements are the D5F3 clone and the 5A4 clone. Now, ALK is normally not expressed in lung. It's an embryonically expressed gene that gets shut down for the most part in adult human tissue. And there's a clone called ALK1, which does work. It's made by Dino sells it, but it can recognize the ALK rearrangement in anaplastic large cell kinase, anaplastic large cell lymphoma, and in IMF tumors. But it doesn't work for detecting the ALK rearrangement in lung cancer because the levels of the protein that are being made are too low. So these are more sensitive and they can detect it. But one important feature is that the staining can be incredibly faint or almost barely perceptible. And that has no correlation to the number of malignant cells that show a gene rearrangement. So anything that even looks faintly brown should be considered positive. So although these are not FDA approved, they could be a very effective screening mechanism. So you can screen your cases, and anyone that looks positive or suspicious of being positive, you can reflex for confirmation with FISH. That's potentially a cost-saving measures that can be taken, considering it's kind of a rare event in lung cancer. The second important gene rearrangement involves the ROS1 tyrosine kinase. This is about 1 or 2% of lung cancers, described a couple years ago as lots of different fusion partners to ROS, and it's very similar to ALK gene rearrangement, patients with ALK gene rearrangements, and that these patients are typically younger in age, usually median age around 50. They have a history of never or light smoking, and a light smoker by definition is less than 100 cigarettes in their lifetime. They have an adenocarcinoma histology. These are much more prevalent in patients of an Asian ethnicity, and there's no overlap with other driver mutations. There haven't been that many cases of ROS1 described in the literature, but this one paper showed that ROS1, which is shown in this blue line, patients with ROS1 translocations do not have a different prognosis than patients with intact ROS1. So it's debatable, it's just not known yet if it has a prognostic implications in lung cancer. But there is a case report of a 31-year-old male non-smoker with lung adenocarcinoma who did not have an EGFR or ALK rearrangement and no response to erlotinib. The patient went on a crizotinib trial and showed a dramatic increase. And then there's been subsequent studies that show a positive response in ROS1 patients to the drug crizotinib, which was designed, which is FDA approved for ALK rearrangements. So it's important to test because these patients may benefit from crizotinib. This is also a FISH-based assay. This is the case we had in our lab, where you see the intact chromosome and the loss of the 5' ROS signal. So you see only this green signal left. So it's about 48% of the cells. This is considered to be positive for gene rearrangement. There's also an antibody made by Cell Saving Technologies in the United States. It's called D4D6. It stains positively ROS1 cases. The issue with this antibody is that it also stains highly cases that are ROS1 negative, about 31% of them. So you get a lot of false negatives. But when you consider that ROS1 is about 1% of lung cancer, if you're going to do FISH on all your cases, it's very expensive and time-consuming. So this is a good first step at developing an easy-to-use immunohistochemistry screen for teasing out your cases that may then need to go on and have follow-up FISH. Then lastly, I'd like to talk a little bit about lung squamous cell carcinoma. There's 3 major mutations that have been described in lung squamous cell carcinoma. There's DDR2 as part of the DDR family of tyrosine kinase receptors. Mutations in this are also in renal cell carcinoma, GBMs, endometrial cancer, and colorectal cancer. There's a case report of a patient who had a S768R mutation in DDR2 who responded to dasatinib. FGF1 is amplified in about 20% of squamous cell carcinoma, and there's inhibitors that are being developed. And lastly, there's mutations in PIK3CA, and these can occur similarly with the EGFR mutations, and there's trials looking for inhibitors of PIK3CA. This is not a very major driver mutation. It can happen with other mutations, and it's probably more of a secondary or semi-potent driver mutation. Okay, now colon cancer. Patients with colon cancer, a significant portion of them can be cured by surgical intervention, particularly because it's screened and caught kind of early. But following resection, there's still a risk of recurrence, particularly in patients with stage 3 and some patients with a high-risk stage 2 cancer. In these patients, adjuvant chemotherapy can reduce the risk of recurrence. And adjuvant chemotherapy in colon cancer is based around 5-FU. That was the first drug that was used, and then leucovorin was added to it. This is the mainstay in adjuvant chemotherapy. But microcellular instability is very important to do in patients who are candidates for getting adjuvant chemotherapy, because patients whose tumors demonstrate the microcellular instability high phenotype do not respond well and don't respond actually to 5-FU, and it's not recommended they get 5-FU. So this is an important test in helping to select patients for adjuvant chemotherapy. And another point to make is that the two targeted therapies in adenocarcinoma of the colon, which are cetuximab and panitumumab, these are monoclonal antibody inhibitors, are not used in the adjuvant setting. These are more used in the metastatic setting. So MSI, so screening for KRAS mutations to look for resistance to these two drugs really is not indicated for patients who are considering adjuvant chemotherapy, because they're not going to get these drugs at that time. So patients with stage 3 who are microcellularly stable have been shown to benefit from 5-FU-based adjuvant chemotherapy. But if these patients have microcellular instability high, this is not proven, but the evidence suggests that these patients don't really benefit as well from adjuvant chemotherapy and may just be considered cured. And at Medical College of Wisconsin, I've talked with our clinicians, they typically, in their early stage 3 patients who are microcellular instability, they don't offer them adjuvant chemotherapy. Some institutions in patients with stage 2 colon cancer who have high-risk factors, those high-risk factors are histological factors on the specimen I described here, may be offered adjuvant chemotherapy. It's debatable, the efficacy of that, but if these patients are microcellular instability high, they don't get adjuvant chemotherapy. So the take-home point is microcellular instability high phenotype would argue that adjuvant chemotherapy is not beneficial. And this is one of several studies that have been done that have demonstrated this. Patients with stage 2 colon cancer, microcellular instability high phenotype, who get 5-FU in this blue line do worse than patients who don't get 5-FU adjuvant therapy. And the reciprocal is true in stage 3 patients who are microcellularly stable. Surgery alone does worse than when patients get adjuvant chemotherapy with 5-FU. And these two cases here are just kind of the other two combinations, and it's difficult to interpret what the benefit is there. So MSI testing can be done 2 ways. One is an immunohistochemical panel against the 4 genes that are involved in mismatch repair. There's 5 different possible readouts from the microcellular instability staining patterns. Most often than not, all 4 of the mismatch repair genes are expressed. It's about 85% of the cases. This would be microcellular stable. And at the same time, you're screening for Lynch syndrome, which is a genetic disease in which you have a mutation in one of the 4 mismatch repair genes. These are unlikely to have Lynch syndrome. The second most common pattern would be loss of both MLH1 and PMS2. This typically is sporadic because MLH1 can be lost or silenced by epigenetic changes, which means it gets methylated. But if you were to sequence it, there's no mutation. And when MLH1 is not expressed, PMS2 does not have a binding partner, so it gets degraded. So you have secondary loss of PMS2. It could also be Lynch syndrome, but it's more often than not than sporadic cancer. Now, loss of MSH2 and secondary loss of MSH6, loss of MSH6, or loss of PMS2, these are all diagnostic of Lynch syndrome. So young patients, younger than 50, should always be screened for Lynch syndrome, and this pattern of staining would help to further work on those cases. An alternative method would be a molecular method called microcellular instability analysis. In this situation, DNA from the normal part of the tumor and the malignant part of the tumor is extracted. You need both normal and malignant DNA to test. And then there's 5 microsatellite markers that you do PCR on, and you look for the size of the microsatellite peak. And so you look at the microsatellites in the normal fraction, then you look at them in the malignant fraction. You can see in a patient with microsatellite instability due to defects in the mismatch repair proteins, you have the intact microsatellite and then a second set of peaks. This is really easy to interpret. And this shows that this patient has microsatellite instability in 5 out of 5 microsatellite loci. That would be microsatellite instability high. So to do this test, you have to have both normal and tumor. So you get a little biopsy or something that doesn't have a normal component. You can't do this test. You're better off doing IHC. And you should not do this test in patients who have rectal cancer that have been previously treated with radiation, because radiation can damage the DNA and can give microsatellite instability in some of the loci. It's kind of like pseudo-microsatellite instability. One interesting thing we've noticed in our lab over the last couple of years is that we screen a lot of endometrial cancer with microsatellite instability for Lynch syndrome and through colon cancer. And the two have a completely different phenotype by PCR. Endometrial cancers, the microsatellite changes or those shifts in the nucleotides, which is what I'm showing here. You can see the shift from right to left is very subtle. Sometimes it's a single nucleotide shift. And initially you might blow it off or think it's normal, or there's really no criteria to say how many nucleotides does that have to shift. So a resident in our program went and looked at all of our cases and came up with a way to tally up the number of shifts. And what we see is that endometrial cancer, the shifts are much lower. And the way to, so we decided to correlate this using immunohistochemistry as a gold standard. And what we found was that when you see a nucleotide shift of 1 and 3 or more microsatellite markers, that has the highest sensitivity and specificity for detecting mismatch repair defects. And that's very subtle and can be easily missed. So it's important if you look at these chromatograms and you're looking at endometrial cancer to pay attention to these single nucleotide exchanges because they're real and they reflect something. And these subtle changes really don't happen in colon cancer. When they shift, they really shift. So it's not really a problem. So if you're going to, endometrial cancer is good to do both IHC and MSI because that's your best way of maximizing your odds of detecting a case that has mismatch repair defects. KRAS and NRAS are important to screen for in patients with metastatic colon cancer who are candidates for cetuximab. Collectively, about 50% of colon cancer has a mutation in either KRAS or NRAS, with KRAS being much more commonly mutated. There's a high concordance between primary and metastatic lesions. So if a patient develops metastatic colorectal cancer, but there's no biopsy sample, it's okay to test the primary for KRAS and NRAS status. Now, what conventionally has been done up until recently was people just looked at codons 12 and 13 and exon 2 of KRAS. And that was a complete part of their analysis. But NCCN guidelines recommend that a full mutation panel of KRAS and NRAS be performed, which includes much more rare hotspots in exons 3 at codon 61, exon 4, and the entire NRAS gene. So if a patient is going to go on cetuximab or panitumumab, it's important to interrogate all these positions, because if they have a non-exon 2 mutation, say exon 3 that wasn't interrogated, the patient goes on to targeted therapy, they may not respond well to it, or it may have a detrimental effect, so it's incomplete. So it's important to develop an assay that looks at all these mutational hotspots. Lastly, BRAF is frequently mutated in colon cancer, about 10 to 15% of patients. And this is mutually exclusive with KRAS. And the BRAF mutation in the absence of microsatellite instability phenotype has a very poor prognostic indicator. And these patients have a very shortened median survival. And the role of BRAF as a predictor of response to EGFR targeted therapy is unclear. Many groups consider that a BRAF mutation predicts lack of response. There's some evidence that there may be an attenuated response to targeted therapy. People have tried looking at the vemurafenib inhibitor in colon cancer, which this is a drug that's normally used in melanoma. Those results have been disappointing. And in fact, when these patients are treated with this drug, there's some evidence that it gives a positive feedback on the EGFR and actually stimulates tumor growth. So ascertaining the BRAF status and the KRAS status in metastatic melanoma is important because there's different treatment arms that be available to the patient based on the genotype of their tumor. This is described here. So some other important mutations in colorectal cancer include AKT1, it's about 1 to 6%. It has a hotspot at the glutamic acid position 17. It's an activating mutation. These mutations are likely to be mutually exclusive with PIK3CA or PTEN. All 3 of these genes are in the same signaling pathway. Clinical trials are underway looking at inhibitors of AKT1. Same with PIK3C. It's commonly mutated in colon cancer. It does overlap with other driver mutations. There's clinical trials for it. PTEN, same thing. It's commonly mutated. Clinical trials exist for patients who have PTEN mutations. Then SMAD4 is another molecule. There's no active clinical trials in the U.S. as of now, but it's frequently deleted in colon cancer or mutated at these hotspots. It's believed to be a bad prognostic indicator.